Good morning, good afternoon, and good evening, depending on the time zone you are in. Welcome to the scientific session on culture-independent testing, a new way to hurdle obstacles for detection of sepsis-causing pathogen and improve patient outcomes. I am Dr. Aparna Ahuja, currently the Chief Medical Officer at T2 Biosystems. I provide leadership and strategic direction for all medical, clinical, scientific, and regulatory affairs activities. I'm a strong advocate of patient and healthcare worker safety with a career of almost 3 decades in lab medicine and medical affairs in medical device in vitro diagnostics. I'm an advisory board member of Pain Care Labs, corporate advisory board member of American Association of Clinical Chemistry, chair of AACC New Jersey chapter, CLSI expert panel member, auditor with CAP and ISO 15189, and active member of various lab and medical associations. I would now like to introduce the speakers of our session today. Dr. Pankey, he's the Director of Infectious Disease Research at Ochsner Clinic Foundation in New Orleans, Louisiana. He also is a clinical professor of medicine at Tulane University in New Orleans. Dr. Pankey created the section on infectious diseases and the Infectious Disease Fellowship Training Program at Ochsner Health. He served as head and program director of these programs for more than 20 years. Dr. Pankey has authored or co-authored 5 books, 30 book chapters, and more than 160 peer-reviewed journal articles. Of special interest to him are the areas of antimicrobial therapy and resistance. He's a member of editorial board of Infectious Disease News. He received the Clinician Award of the Infectious Disease Society of America and Mastership in the American College of Physicians. Dr. Hong is the professor and director of Transplant, Infectious Diseases and Antibiotic Management Program at University of Pittsburgh Medical Center. Her research focuses on antibiotic-resistant bacterial infections and antimicrobial stewardship research, including projects on evolution of resistance and pathogenic mechanisms of carbapenem-resistant Enterobacteriaceae and other gram-negative bacteria, the development of novel antibiotic treatment strategies, the clinical and economic impact of AMR infections, and antimicrobial stewardship interventions. Dr. Hong's transplant infectious diseases research include projects on the role of the microbiome in infections and outcomes among transplant recipients, and clinical trials on a wide range of opportunistic fungal, bacterial, and viral infections. She has published numerous papers on optimal use of rapid non-culture test in diagnosing sepsis and acute infections, and in antimicrobial stewardship interventions. I will be talking on culture-independent testing for timely detection of sepsis-causing pathogens. Sepsis, as you know, is a burdensome condition worldwide in terms of morbidity, mortality, and healthcare costs. Sepsis is the body's extreme response to an infection and is potentially life-threatening medical emergency. Without timely treatment, sepsis can rapidly lead to tissue damage, organ failure, and death. Early treatment improves chances of survival. Sepsis represents $62 billion in US healthcare costs and claims more lives each year than 3 leading causes of cancer deaths combined. CDC data states that each year, 1.7 million adults in the US develop sepsis. 270,000 Americans die as a result of sepsis. 1 in 3 patients who die in the hospital has sepsis. Another concerning fact is that hospitalized COVID patient as compared to the hospitalized influenza patient faces a 22% higher risk of developing sepsis and is 113% more likely to experience septic shock. Antimicrobial resistance is on the rise globally and is one of the biggest public health challenges of our times. The CDC reports that each year in the US, at least 2.8 million people get an antibiotic-resistant infection and more than 35,000 die. That means on average, someone in the US gets an antibiotic-resistant infection every 11 seconds, and every 15 minutes someone dies. Antimicrobial-resistant infections are estimated to cause 700,000 deaths annually worldwide. As we know, the cornerstone of sepsis management is prompt administration of antimicrobials with activity against the causative pathogen. Indeed, Delayed administration of optimized antibiotics is associated with progression from severe sepsis to septic shock and increased rate of adverse events, mortality, and healthcare cost. The extended time for presentation to appropriate therapy continues to be a major contributor to poor patient outcomes and proliferation of antimicrobial resistance. Current standard of care requires up to 3 days to provide sepsis ID and susceptibility results, which can delay time-sensitive, life-saving targeted treatment. Survival decreases by 7.6% during septic shock for every hour delay in time to appropriate therapy. Also, prolonged use of broad-spectrum antimicrobial is a key risk factor associated with the development and spread of antimicrobial-resistant organisms. We also know that rapid diagnosis and treatment could prevent as many as 80% of sepsis death. Today, we will discuss how culture-independent diagnostic tests could break new ground in diagnosis of sepsis-causing pathogen and enable timely targeted therapy and appropriate sepsis management. The left side of the slide is the time of sample collection, and you can see it takes about 1 to 5 days to get a positive blood culture. The culture-based rapid diagnostic test can provide species identification in 1 to 3 hours only after a positive blood culture. And on an average, it takes about 48 to 72 hours to get a positive blood culture. These tests cannot be leveraged until the culture becomes positive and cannot be utilized in cases of culture-negative sepsis. The culture-negative sepsis is a common clinical concern where the patient appears septic with a lack of pathogen growth on blood culture. Non-culture-based tests like T2 biosystem panels are not reliant on culture positivity or influenced by antibiotic intake prior to the test. T2 biosystem diagnostic panels are the only FDA-cleared and CE-marked test that provide species identification direct from whole blood within 3 to 5 hours. Blood cultures are the current standard for sepsis management, as all of you know, and the guidelines recommend that appropriate routine microbiologic cultures always should include 2 sets of blood cultures, aerobic and anaerobic, and 8 to 10 ml of blood is required per bottle. And the time to positivity for blood culture could vary from 1 to 5 days, and on average, it will be 2 to 3 days before turning positive. And as we discussed earlier, the species identification in culture-dependent diagnostics can happen only after the blood culture turns positive, which would take at a minimum of about 2 days. While using a test like T2, which is direct from whole blood, it can be done within 3 to 5 hours, and actually SARS-CoV-2 can be done within 2 hours, less than 2 hours. And this is directly put on the instrument, and species-specific result it comes within 3 to 5 hours, enabling targeted therapy. T2MR is the first and the only detection technology that can quickly and accurately identify molecular targets within patient samples without the need for purification or extraction of target molecules from the sample. Thus simplifies process and eliminates these time and labor-intensive steps. The T2MR diagnostic signal is not compromised or disrupted by the sample background, even for highly complex sample background present in blood from patients suspected of having sepsis. It's a proprietary methodology enabling inhibition-free DNA amplification in complex clinical matrices, so there's no background interference, example from human DNA or even from antibiotics. And T2MR enables measurement direct from patient sample, which enables higher sensitivity. FDA-cleared T2Dx instrument, it is fully automated, walk-away clinical multiplex benchtop diagnostic system capable of running tests directly from whole blood. The species-specific results in 3 to 5 hours with no upfront sample preparation. And it's a fully automated system with minimal hands-on time. A sample tube, a reagent tray, just snaps onto a cartridge, which is then inserted into the instrument, and thus it's very easy to operate. You need only 4 ml of whole blood, and no blood culture is required to receive the T2 identification results for targeted pathogens. So just saying it again, that you need to just put a 4 ml whole blood EDTA tube into this instrument, and there's no blood culture that is required prior to it. It's random access, 7 individual random access drawers, which can be loaded at any time, and no batching is required. It's a simple user interface, so user-friendly touchscreen display, which provides step-by-step text and illustrative prompts that guide the operator to load a sample, all in 10 minutes or less. There are 4 panels currently available, out of which 2, that is T2 Candida and T2 bacteria, are FDA cleared. The T2 resistance panel, it is CE marked and RUO use only, and currently it is not FDA cleared. The T2 SARS-CoV-2 test, it has got EU approval, and you can note that the limit of detection is very low, up to 1 CFU per mil. And as we know, with this COVID-19 pandemic, there are many new challenges, one of them being of increased risk of secondary infections, sepsis, and septic shock. Thus, treating secondary and co-infection in timely manner is become even more critical than it always was and has been. Overuse of antibiotics for COVID-19 patients is driving cost and resistance. I wanted to share a multi-center retrospective cohort analysis, which is done recently, published recently in 2021 from 241 acute care hospitals of 490,000 patients evaluating COVID-19 and secondary infections. This shows that SARS-CoV-2 positive patients were almost 2 times as likely to have a pathogen detected during the hospital onset period compared to COVID negative patients or untested patients. Longer hospital stay and longer ICU stay for patients that tested positive for SARS-CoV-2 and a secondary pathogen. The Director General of the World Health Organization, Dr. Ghebreyesus, stated that the COVID-19 pandemic has led to an increased use of antibiotics, which ultimately will lead to higher bacterial resistance rates that will impact the burden of disease and deaths during the pandemic and beyond. And it's a fact that overdiagnosis of these critical cases becomes acceptable because overtreating is less harmful than missing secondary infection and sepsis. This is leading to overuse of antibiotics, leading to antimicrobial resistance and increased healthcare costs. This highlights the requirement of a rapid and accurate diagnostic test for these cases. And it's been seen that the antibiotic prescribing in COVID-19 patients has ranged from 58 to 100%. And the lack of antimicrobial stewardship intervention may lead to wide use of broad-spectrum antibacterial treatment in COVID-19 patients, despite insufficient evidence. Coming to the T2 biosystem panels, which are direct from whole blood and can provide the accurate diagnostic test within 2 to 5 hours, depending on which panel you use. I wanted to share some recent data of 2021. All of these are prospective studies, and you can note that all of them demonstrate high sensitivity and specificity of these panels, the faster time to result, escalation and de-escalation of antibiotics can also be done in timely manner, thus saving costs. A recent publication on meta-analysis of 14 studies evaluating antimicrobial and resource utilization with T2 magnetic resonance for rapid diagnosis of bloodstream infection shows the results as follows. There's faster time to detection and species identification with T2MR by about 3 days, faster time to targeted antimicrobial therapy for patients testing positive on T2MR by 42 hours, and faster time to de-escalation from empirical therapy for patient testing negative on T2MR by 7 hours, and shorter length of ICU stay and hospital stay by 5 days. All these 14 studies were controlled. There is growing number of real-world evidence of positive impact of T2 Candida and T2 bacteria panels on patient care and antimicrobial stewardship. This slide states some of these publications, and across all these hospitals, we note reduction in median ICU and overall length in stay, faster initiation of targeted therapy, as well as discontinuation of antimicrobials and hospital savings. Thank you. Now I'll hand over to Dr. Hong.
Thank you, Dr. Ahuja. Please see my disclosure on this slide. The outline of my talk presenting here. Today, I focus mainly on the two derived from blood T2 panel. First, I will discuss the clinical performance data of T2 resistance. Then I will briefly review our experience of early incorporation of T2 bacteria in clinical practice. To remind everyone, T2 resistance panel is for research use only. This is a derived from whole blood test that detects 13 resistance marker among gram-positive and gram-negative bacteria. The objectives of our study are to evaluate the clinical performance of T2 resistance panel, and number two, to determine a possible impact of T2 resistance in the time to effective therapy among patients with bloodstream infection. So, as you can see on this slide, over 1 year period, we obtained the whole blood sample from patients with bloodstream infection due to gram-positive cocci or gram-negative rot. These remnant blood sample underwent T2 resistance testing for identification of resistant markers. At the same time, we obtained the bacterium isolate from the blood culture and we tested for susceptibility. These bacteria are further classified into 4 distinct groups. MRSA, harvesting MAC-A and C genes, VRE for VAN-A and VAN-B genes, and ceftriaxone or carbapenem-resistant Enterobacteriaceae, which are phenotypic markers for production of ESBL or carbapenemase. And the last group are the T2 resistant negative markers bacteria. Before I show you any data, I think it is very important for me to discuss about the approach at our own institution for patients with sepsis, because this approach might interfere with the time to appropriate antibiotics. So when a patient develops a sepsis or septic shock, and in whom the cause of infection is unknown, it is recommended for them to be treated with empiric antibiotic with vancomycin and cefepime. Then when the blood culture turned positive, the staff in the microlab perform the gram stain, and the result will go directly to the treating physicians. The physician have 2 options. Number 1 is either continue the patient on the current antibiotic, or if they want to broaden the antibiotic or need assistance in selection of antibiotic, they can call our antibiotic stewardship team. So over the study period, we enrolled 103 patients who were infected in the blood with 113 bacteria. 10 patients had polymicrobial bacteremia. The bacteria recovered from blood are summarized here on this slide. Pertinent to this talk, 55 out of the 113 bacteria actually produced were positive for a T2 resistant target. These include CTXM 1415 among the Enterobacteriaceae, KPC3 producing Enterobacteriaceae, and MAC-A and C among MRSA or MRSC bacteria, and 16 bacteria producing VAN-A or B from the vancomycin-resistant Enterococcus faecium. overall, the T2 resistance panel sensitivity is very sensitive in detecting VAN A, B, CTXM, KPC, and plasmid producing MC. The overall sensitivity of T2 resistant panel in detecting these markers were between 92 to 100%. The overall specificity was very high, ranging between 99 to 100%. In order to understand the possible impact of T2 resistance in time to appropriate antibiotic, we divided the bacteria into 4 groups. Those that produce MAC A and C, like within MRSA or MRSC. Those who produce CTXM or KPC among ESBL or KPC producing Enterobacteriaceae. Those bacteria producing VAN A or B within the VRE. And lastly, the bacteria in whom there is no T2 target identified. And these bacteria are presented here. So overall, the median time to appropriate antibiotic was 16.3 hours. However, when we stratify the bacteria by specific group, as I presented in the previous slide, bacteria with no T2 target identification, bacteria with MAC A or C, VAN A or B, or ESBL KPC, what we found was that the time to appropriate antibiotic was significantly longer for patients infected with a VRE, 25.6 hours here, and those infected with ESBL or KPC Enterobacteriaceae. The time to appropriate antibiotic approached 51 hours. And these were significantly higher than the patient infected with bacteria in which the T2 resistant target were negative, 6.7 hours. We think that the reason of this big discrepancy in time of appropriate antibiotic was due to the selection of empiric antibiotic for septic patients at our center. We next evaluate the impact of the result from the micro lab into the selection of antibiotic therapy for our patient with bacteremia. So again, we divided the patient into criteria into 4 groups. Number 1 is antibiotic selection empirically before any culture turned positive. Then antibiotic selected based on gram stain, based on the speciation of the bacteria by Monditov, or based on the susceptibility data. This slide is a little bit busy, but please let me walk you through this. On the x-axis, you have the 4 categories that I just mentioned about. Empiric therapy, gram stain directed, Mondi directed, bacterial speciation directed, and sensitivity directed antibiotic selection. On the y-axis is the percent of patients receiving appropriate antibiotic therapy. The blue line here represents patients who were infected with the bacteria with no T2 markers, T2 resistant marker. The bar graph in gray and black represent patients who was infected with either vancomycin resistant Enterococcus, Fishium, or due to ESBL or KPC producing Enterobacteriaceae. So when you look at the empiric therapy, it's overall 63% of patients who were infected with bacteria with no T2 resistant marker, 63% of those receive appropriate antibiotic therapy, compared with the dismal number of 18% and 30% among patients infected with VRE or patients infected with ESBL or KPC Enterobacteriaceae. Furthermore, when the blood culture turned positive and the result of the gram stain were called into the treating physician, only 54% of patients with VRE infection and 40% of patients infected with ESBL or KPC Enterobacteriaceae receive appropriate antibiotic. And the most concerning was that even when the species has been known and input into the medical record, 60% of patients infected with CTXM or KPC, only 60% of them receive appropriate antibiotic therapy. If a T2 resistance panel are introduced at the time of sepsis, the appropriate the time to appropriate antibiotic therapy for patients with VRE or ESBL/KPC Enterobacteriaceae bloodstream infection might receive appropriate antibiotic therapy around the time of sepsis. So in conclusion, there was a significant delay in administering appropriate antibiotic therapy to patients with bloodstream infection, especially among patients infected with VRE or ESBL KPC producing Enterobacteriaceae, even at institutions with robust antibiotic stewardship support like ours. The T2 resistance panel rapidly and accurately detected bloodstream infection caused by VRE and ESBL KPC producing Enterobacteriaceae. Thus, it has the potential to significantly shorten the time to appropriate therapy. For the rest of my talk, I'm going to spend time to go over with you the data. This is very early data on how we incorporated the T2 bacteria in clinical practice. So to remind everyone, T2 bacteria panel identify 5 of the 6 escape organisms with very good sensitivity and specificity. T2 bacteria has been FDA clear test for several years now. However, until today, we still need to obtain data to really justify how to incorporating this test into the daily flow of clinical practice. Based on my experience, there are several obstacles to introduce this into the clinical practice. Number one is that T2 bacteria only cover 5 bacteria within the escape organism. And due to the cost constraint, the T2 bacteria clearly cannot be ordered every single time that the blood culture was ordered. And today, the indication for assay utilization are not clearly given, and the positive impact of this assay on patient outcome has not been shown. So the question is, how can we incorporate T2 bacteria in clinical practice? When do we send the test and in which population? To me, there are three prerequisites for performing the test. Number one is that the patient have to have a very high likelihood to have a bloodstream infection due to the 5 of the escape organism. Number two is the mortality rate should be high if the time to appropriate antibiotic to this patient are delayed. And number three is that the rate of resistance is high. Only when you meet these 3 criteria that you will be able to show the impact of this T2 bacteria. So University of Pittsburgh Medical Center is a large transplant center, and I'm the transplant infectious disease taking care of this patient. So for a proof of concept of how to use this test, we targeted the solid organ transplant. And this patient fulfilled the 3 criteria that I discussed with you. They have high rate of bloodstream infection due to escape organism. The mortality rate is high, and they have been increasing in antimicrobial resistance among the bacteria infecting this patient population. Among all the solid organ transplant, liver transplant stand out to be the patient population that most benefit from this test, because the procedure of transplant in liver is a technically complex procedure that is performed in a contaminated environment within the abdominal cavity. when the patient get infected, the most common organism is the enteric pathogens, and most of these pathogens are included in the T2 bacteria panel. And in addition to that, 30% of our Enterobacteriaceae are resistant to ceftriaxone and H3N, which is a hint for ESBL producing, and 15% of our isolate were resistant to carbapenem resistant. So we did a retrospective chart review over 2 years of 153 liver transplant patients. And we look at the incidence of bloodstream infection within 6 months after transplant. 21% of these developed infection, and among which 69% of these infections were due to the 5 organisms included in T2. So we designed a study where we enrolled all the patients who would receive a liver transplant within 6 months. Anytime that they develop signs and symptoms of sepsis or septic shock, a blood culture and a simultaneous T2 bacteria were drawn. Anytime that the T2 bacteria result is positive, it will be an automatic consent to transplant infectious disease team. So to date, we have enrolled 7 patients, and among these, 4 patients of 57% developed bloodstream infection. Among the 4 patients with bloodstream infection, 3 were due to the bacteria that are including in the T2 bacteria target. So we next look at the impact of T2 bacteria on the management of this patient. I can concentrate on the 3 patients that were infected with the bacteria detected by a T2 bacteria panel. The bottom line is that in all of these 3 patients, the target that were identified within T2 bacteria were later confirmed by the positive blood culture. And in each of these 3 bacteria, each of these 3 patients, the antibiotic were escalated to anti-VRE or anti-pseudomonone therapy based on the early result. Lastly, the last patient here, the T2 bacteria target identified 3 species, Klebsiella, Pseudomonas, and VRE. Although over the next 72 hours, the blood culture only grew out Klebsiella. So, you know, our transplant IT team was very concerned because of the patient might have a deep-seated infection due to the other 2 organisms. So we went ahead and got a CAT scan, and we diagnosed unexpectedly that the patient actually had an abscess in the liver. Aspiration of this abscess fluid grew out Pseudomonas and VRE, and we diagnosed this 5 days after the knowledge by the T2 bacteria target that Pseudomonas and VRE were found in that. So based on this experience, we think that T2 bacteria make an impact on appropriate antibiotic and sometimes can help or assist the clinician in ordering tests to look for other deep-seated sources of infection. So in conclusion, in appropriately targeted population, T2 bacteria effectively changes the management of liver transplant patients with sepsis. Preliminary proof of concept data form a conceptual framework that showed that incorporating T2 bacteria into the rational patient management is possible. Similar exercise can be undertaken for other populations at risk for bloodstream infection. But the key thing is you need to know your patient population at risk for escape organism causing infection, and you need to know your antibiogram to direct appropriate antibiotic therapy. T2 bacteria and maybe in the future T2 resistance has potential to accelerate time to the appropriate antibiotics for targeted bacteria. But it is very important that we incorporate the antibiotic stewardship team or physician in the intervention. A top priority is to define at this time the T2 panel precise role in clinical practice and their effect on patient outcome. A question that still needs to answer is whether shortening time to the species identification or shortening time to resistant determinant can actually lead to improved patient outcome. Thank you very much for your attention.
Good morning. I'm going to present a pilot study that we've done at Ochsner Health in New Orleans on the research use only T2 resistance panel in patients with blood culture positive bacterial infections. Our hospital is 767 beds. It's a tertiary hospital. We fortunately stayed open for IDA, had some water issues, but otherwise operating, we didn't lose any power. So that was the important issue. In 2020, our IRB approved this study, and we actually couldn't start it until January of 2021 because of COVID issues. The next slide. As a background, you've already heard that T2 resistant panel includes detection and identification of 13 antibiotic resistant genes and gram-negative and gram-positive bacteria. And I think it's important to remember that this includes both living and dead bacteria. The organisms don't have to be alive for you to pick up these genes. And also, the genes can occur in any of the bacteria that might have them. It doesn't have to be on the T2 bacterial panel. Sensitivity limit is as low as 3 colony-forming units per ml of whole blood. And the analysis time is 3 to 5 hours, which has been emphasized, but that is 3 to 5 hours from the time you put it into the machine. And there is some few hours to get your specimen down there. And fortunately, this can be done by keeping the specimen at room temperature for a short period of time and then in a refrigerator. This, the primary objective of our study was to evaluate the diagnostic accuracy of the T2 resistance panel and compared with the antibiotic susceptibility reported in our diagnostic laboratory. So we were interested in sensitivity and specificity. A secondary objective was to determine how the results would impact treatment decisions, and we have not even started on that. And we further wanted to evaluate the T2 bacterial panel. So originally we were going to use the T2 resistance panel only on T2 bacterial panel positive bloods. The next one. The T2 resistant 13 gene panel, you've heard about some already. It's actually reduced to 7 probes for the machine. And I have this slide up. I'm sure you'll have it available to look at, because one of the problems with resistance factors is the same thing with taxonomy with microorganisms. They change and they make it too complicated. For example, the OXA class D genes, it's named OXA because it's produces a lot of oxacylinase, but it also is a carbapenemase producer. And then they use the names of where certain resistant genes were discovered. It's important, I think, to remember that any gram-negative rod theoretically could have any of these resistant genes present. The next slide. Our procedure, and I'm just going to review this because it sounds easy when people present these kind of studies, but it turns out it's not so easy for many of us to do. Our procedure was a blood culture order is placed by the patient's care team, patients being 18 years of age or older. We have people that are looking at this about every 15 to 30 minutes, and they look at Epic and get this information. Then they try to go to where the patient is and get a verbal informed consent. And then they have to be there when the blood culture is collected by an RN, a phlebotomist, and we collect 3 vacuum container tubes, about a tablespoonful of whole blood, from the same needle stick that the blood culture has gotten. And this is, we try to do this for the first of 2 blood cultures that are frequently ordered for sepsis patients. And this was our paired sample. And we froze all of the samples at -70 centigrade until we tested them, because this is a research use only project, and this information was not being used for patient care. Screen fails were very common. Veins collapse, it's low blood volume. Sometimes there's difficulty in getting the proper information, and anyway, it's not as easy as you would think. The next slide. The blood cultures are handled in our diagnostic lab according to our standard procedure. We use a Biotech FX, and then the MALDI give us the species and susceptibilities performed by a microscan walkaway. So that's our comparison. We freeze all of the blood isolates that we get at Ochsner and keep them in our lab that are not considered contaminants. If we get 2 or more blood cultures with a coag negative staph and it's clinically relevant to the patient, that's included. The next slide. In addition, for this little study, we not only looked at the specimen that we got at the time the 1 blood culture was done, but we looked at results of blood cultures that were obtained 48 hours before, and sometimes the same day of the one that was paired. And our idea was that we would go back then, and if the paired specimen was negative and a 48-hour window specimen was positive, then we would do the resistance panel on it to see if there were any resistance genes there, as well as having had the other information. And of course, we're comparing the results with susceptibility in our lab. We've considered 641 patients as of a couple of days before Ida hit. We have 432 adequate blood samples for testing. We're trying to get to about 1,000. And these blood cultures, whoever orders them, they're not specifically in any one area of transplant or oncology. A lot of them come from the emergency department, but there's no specific requirement there. And of those that we've done so far, we have 15.5% positive, either paired or within the 48-hour period. Next slide. The resistant genes in the T2 resistance panel were possibly present in 61 of 67 of these positive blood cultures. That's 91% that theoretically could have been benefited by this test. And it correlates very well with what Dr. Nguyen has reported. The next slide. Of the 27 T2 bacterial panel positives, we have tested 17 of those, or 63%, with the resistance panel so far. And of those 17, we had 16 agree with the diagnostic lab susceptibility result, which is a sensitivity of 94%. Now, unlike Dr. Nguyen's experience, our 7 E. coli's were all susceptible to everything. There was no ESBL found. And that was the same thing for the T2 resistance panel. For Staph aureus, we had 1 MRSA and it was picked up, but and the 3 that had no MEC-AC were also diagnosed appropriately. And the same thing was true for the 3 Ephesium, having 2 resistant ones and 1 susceptible. Our 1 Klebsiella pneumoniae and 1 Pseudomonas were totally susceptible. We have not tested yet a couple of Enterobacters and a couple of Klebsiella oxytocus, which are included in the total number of 67 positives. The one that was aberrant for the T2 resistance panel was a VRE Fecium that was on the blood culture, which also had an MRSE. The T2 bacteria picked it up as a E. Fecium because T2 bacteria doesn't have staph epi on it, but it did not pick up the MEC-AC from the methicillin-resistant staph epidermidis that was on the antibiotic susceptibility. The next one. We also tested 100 samples from patients that had a negative blood culture, and they also had no positive blood cultures 48 hours before and after. And there was no resistant genes detected. So it was 100% specificity. So from our brief study, which is ongoing, we confirm really what everybody else has seen so far. The sensitivity is in the 94% for us, specificity is 100%. So we're looking forward to many more tests with this and hopefully getting more data. Thank you for your attention.
Thank you so much, Dr. Hong and Dr. Pankey, for your excellent presentations and sharing your research and clinical data with us and all the participants. So I have a question for Dr. Hong. Since you shared with us how you suggest that the T2 panels could be incorporated into clinical practice, I just wanted you to share the key message that you have on how do you envision the incorporation of T2 resistance into clinical practice.
As I mentioned in my talk, I think the key point that we should have is that we have to target the antibiogram at that specific hospital. They have to have MRSA, VRE, and either ESBL producing or gabapenimase producing, because that's what the T2 resistance panel is going to help us to accelerate the appropriate antibiotics. What I was so surprised in our study was that I always thought that our antibiotic stewardship team is very good. I think our team has like a 6 physicians and 6 pharmacists on board. And when we look at time to appropriate antibiotic in the VRE among the patient infected with VRE or ESBL, this is it provides us with a window of opportunity if we can incorporate the T2 resistance panel into the clinical practice, because we can shorten the median time of like 50 hours down to like just a few hours after the patient presented with sepsis.
So the time to the appropriate therapy could be decreased by, I mean, what I'm hearing is maybe about by
2 days, by at least 2 days. Yes.
So that's very powerful. So thank you so much for sharing your research and your perspective on this. And since I'm asking you the question, the other question was on T2 bacteria. It has the escape pathogens, and so how you can advise and envision the using or leveraging this panel in clinical practice.
You know, our hospital is very subspecialized into units, so that's how we were able to do the study. But you know, I think the bottom line is if you want to introduce T2 bacteria into your hospital, you really have to know your unit, or at least the patient population at highest risk, not only for bloodstream infection, but also bloodstream infection due to escape organism. So we started out with the liver transplant, but you know, other scenario that we have been talking about is we are looking at people with abdominal, intra-abdominal, or GI surgery, because those patients are at high risk to be infected with enteric organism, and all of these enteric organism or the majority of the bacteria are included in the T2 panel. So you have to have an algorithm in place, target the specific patient population, and whenever the test come back to be positive, you have to have a stewardship team or physician there to guide the physician to escalate into the appropriate antibiotics.
Thank you so much. And could you also share with your experience? You already shared, but just it'll be nice to hear it again. Maybe one of the most impactful case where you could see the panel, where the bacterial resistance panel to be impacting the treatment and the prognosis of the patient.
Yeah. So this is just my personal bias because it's based on the T2 bacteria that we did a study 2 years ago, and also with the very limited data on the current T2 T2 bacteria, is that the T2 bacteria panel does not only detect the bacteria that cause a bloodstream infection, but also detect the bacteria that cause a deep-seated infection. What I think is that, you know, the patient all along may have may be infected with these deep-seated bacteria as well, but the sensitivity of the blood culture is not good enough to be for the blood culture to grow the organism. So just like our previous study on T2 bacteria, we diagnosed quite a few of patients with deep-seated infection, despite the fact that the blood culture was negative. And this is the same scenario now that we saw in the liver transplant patient. The blood culture can identify only one organism, but actually the patient had deep-seated infection, invasive infection, due to the other two organisms that the blood culture cannot identify, cannot call.
Thank you for sharing this. Dr. Pankey, now I wanted to just ask you this amazing research and the number of enrollments that you've already done. It's very impressive. And your aim to enroll about 1,000 patients is also very, very impressive. Till now, what has been your most interesting finding from the study of the RUO T2 resistance panel?
I think the sensitivity and the specificity. I mean, I'm surprised about that it was so high, actually, pleasantly surprised. We have a lot of work to do. These numbers are small, but when you only have 10 or 15% of the blood cultures being positive, it's very hard to get big numbers quickly. And so this has taken a lot longer than I had hoped it would. And then why have all the E. coli's with no ESBLs when we got others around the hospital? I mean, we just happened to sample that particular group that were totally free of resistant genes, very susceptible. So I think, again, like Dr. Nguyen says, you got to pick your patients. I mean, if you've got a whole group of people coming in with pyelonephritis and an E. coli, you know, maybe you're not going to see as much resistance genes in that particular group of E. coli. Probably won't, unless you're in an area where that's so prevalent. So where you are, the kind of hospital you are, the kind of patient that they're dealing with. We have a lot of liver transplant patients here. We're a big center for that. And one of our big problems is the same, VREs. And but I don't have the same control of patients that are in the transplant unit that Dr. Nguyen has. So I didn't have I don't think we had any of our positives from that group, even though, you know, they're a cooperative group. They're very busy. And of course, we were trying to do ours in the middle of COVID. And that created a lot of problems for us. We have a lot of COVID patients actually in the study. So I don't know if that particular group had, you know, more of the positives or not, because we haven't analyzed that data yet. But
thank you. Thank you. That's very helpful. And you were pleasantly surprised about the sensitivity and specificity. I think that's the strength of the panel, about its negative and positive predictive value, and also the time to detection. I think these are the key strengths. And what I'm hearing from both you and Dr. Hong is that identification of the right patient population, leveraging the antibiogram of the hospital, all these are key essentials which the hospital and the clinical practice, they need to think about while leveraging these panels. And so I wanted to thank both of you for your time today. Thank you so much.
Thank you.